In this video, we are going to discuss about aortic regurgitation. So, aortic regurgitation is backflow of blood from aorta into the left ventricle during diastole due to inadequate closure of the aortic valve. So, it is here the valve is incompetent; it can't close properly during diastole. So, blood from the aorta flows back into the left ventricle because during diastole, the pressure inside the aorta is more than pressure inside the left ventricle. So, pressure of aorta during diastole is 80 mm of Hg, and pressure of left ventricle during diastole 10 mm of Hg. So blood flows from the high pressure zone to low pressure zone if this valve is incompetent or regurgitant valve. So backflow blood from aorta into left ventricle, that will lead to volume overload inside the left ventricle if this happens for a long period of time. So left ventricle eventually adapt and it will undergo eccentric hypertrophy and dilatation. So eccentric hypertrophy and dilatation, that's how it will adapt it. So aortic regurgitation can be divided into acute AR or chronic AR. Acute AR is acute presentation, is emergency, medical emergency. So acute AR, what are the causes of acute AR? One is aortic dissection, infective endocarditis, rupture sinus of Valsalva, right heart failure, and trauma. So these are the four conditions which can present as acute AR, acute aortic regurgitation. One is aortic dissection, infective endocarditis, rupture sinus of Valsalva, and trauma. So I told you, when this backflow blood coming to the left ventricle from the aorta, when this happens for a long period of time, LV will adapt and undergo eccentric hypertrophy and dilatation. So it is suddenly happening in these cases, sudden AR. So LV has no time to dilate and adapt. If it is suddenly happening, LV has no time to adapt. So that will lead to volume overload inside the left ventricle in acute condition. Acutely there will be more volume overload inside the left ventricle, that will lead to increase in left ventricular end diastolic pressure, that will lead to increase in left atrial pressure, that will lead to increase in pulmonary capillary venous pressure or pulmonary capillary wedge pressure, that will lead to frank pulmonary edema and acute dyspnea. So if it is happening acutely or acute AR, it will present frank pulmonary edema or acute dyspnea due to increase in left ventricular end diastolic pressure, increase in LAP, increase in pulmonary capillary wedge pressure, more increased congestion of blood inside the lungs, that will present as acute dyspnea or frank pulmonary edema. So this is the presentation of acute AR. What are other signs we see in acute AR? No other signs of chronic AR will be seen in acute AR. So no feature of wild pulse pressure. There are some signs which are due to wild pulse pressure. They are seen particularly in chronic AR. They will be absent in acute AR. LV failure, cardiogenic shock, and hypotension. So if there is accumulation of blood or volume overload inside the left ventricle, then left ventricle will undergo failure. There will be left ventricular systolic failure. So LV systolic failure will lead to cardiogenic shock and hypotension. So it will present as cardiogenic shock, hypotension, acute onset pulmonary edema, or acute onset dyspnea. This is the presentation of acute AR. So what are the type of murmur will you heard? Murmur is early diastolic murmur, which is heard in case of aortic regurgitation. So short, low pitch early diastolic murmur with soft S1. This will be heard in case of acute AR. So what is the management? Definitive management is surgery. If the patient is awaiting for surgery, you can give nitroglyceride or vasodilators, nitroprusside, inotropes. So I will give them. So remember one thing, that this is suppose aorta, this is left ventricle. The blood is backflowing here. The aorta pressure is more, the left ventricular pressure is less. So that's why the blood is flowing back. So if you vasodilate these peripheral vessels, then there will be decrease in pressure inside the aorta. So this backflow will decrease. So that's why we give vasodilators in management of patients who are waiting for surgery in case of acute AR. Nitroglycerin or vasodilators, nitroprussides, they will dilate the peripheral vessels, that will decrease the pressure inside the aorta. So there will decrease the backflow of blood, which is leading to pulmonary edema, all these things. So vasodilators can be used, inotropes can be used, because inotropes will increase the heart rate and it will decrease the duration of diastole. So that will lead to decrease blood regurgitation from the aorta into the left ventricle. So there is a difference between acute and chronic AR. We will discuss that later. So chronic AR. So what are the causes of chronic AR? Chronic AR can be due to valve-related issue, root-related issue. Leaflet-related issue can be quadricuspid valve. I told you quadricuspid valve is more prone to develop regurgitation. And rheumatic etiology, it can be due to rheumatic heart disease valve involvement. That is another cause of valvular involvement and the cause of chronic AR. Tachyarthritis and ankylosing spondylitis. Root-related issues can be syphilis, Marfan syndrome, Ehlers-Danlos syndrome, and rheumatic etiology like Takayasu-Behcet's, IgG4-related disease, and large vessel vasculitis. So these are the cause of root-related issues: syphilis, Marfan syndrome, Ehlers-Danlos syndrome, Takayasu-Behcet's, IgG4. All these are the causes of root-related issues will lead to chronic AR. So pathophysiology: AV valve doesn't close properly during diastole. So I told you left ventricular diastolic pressure is less than aortic pressure, which is 10 mm of Hg, and aortic pressure is 80 mm of Hg. So there will be backflow of blood from aorta into the left ventricle. We have another syndrome that is called Cogan syndrome. It presents as aortitis, vestibulitis, and interstitial keratitis. So Cogan syndrome presents as aortitis, vestibulitis, and interstitial keratitis. So Hedges syndrome is in case of AS. Cogan syndrome here we see in case of AR. So in case of AR, blood will flow from aorta into the left ventricle due to incompetent valve leaflet, that is called diastolic leak, because the leak is happening during diastole. So LV compensated by eccentric LVH with dilatation. So LV compensated by eccentric LVH and dilatation, but in case of acute AR, this was not happening. So that's why it was presenting with frank pulmonary edema. What is the ejection fraction? Ejection fraction is end diastolic volume minus end systolic volume divided by end diastolic volume. So ejection fraction is normally 60 to 70%. Here the ejection fraction will be normal or increased because the end diastolic volume is increasing. So it can be normal or increased. So left ventricular end diastolic pressure increasing. It can be normal or increased, but it was increasing in case of acute AR. But due to in case of chronic AR, due to dilatation and hypertrophy, eccentric hypertrophy, so it can be normal or increased. So normal blood from the LA and regurgitant blood from the aorta. So during diastole, in case of aortic regurgitation, the ventricle is receiving normal blood which is coming from LA, diastolic filling, and the diastolic leak which is happening due to this regurgitant valve. And severe or decompensated AR. In severe or decompensated AR, there will be systolic failure of left ventricle. So their ejection fraction will be normal or decrease. LV failure will be seen. LV failure means S3 will be heard. S3 is the sound of LV failure. So due to chronic volume overload, there can be LV systolic failure, LV systolic dysfunction. If the LV is not able to pump blood continuously, then there will be blood will accumulate inside the left ventricle. That will lead to increase in left ventricular end diastolic pressure, increase in LV, increase in pulmonary capillary venous pressure, that lead to pulmonary congestion and dyspnea. In the long term, it can develop pulmonary hypertension also, because if there is more blood flow inside the lungs continuously, those capillaries will undergo vascular changes, and it median tunica media of these blood vessels of pulmonary capillaries will undergo hypertrophy, and in the long term it can present as pulmonary hypertension also. So in AR, blood leaks from the aorta into the left ventricle during diastole. It creates a volume overload inside the left ventricle. So there will be increase in preload. Preload is increased. LV receives blood from both LA, which is normal, and diastolic leak from the regurgitant aortic valve during diastole. So afterload, if the preload is increasing, the afterload is also increasing, because preload is the more blood inside the ventricle, so it will pump more. So afterload will also increase due to stretching. Contractility will increase, Frank-Starling law. So more preload, so the ventricles will stretch more. So according to Frank-Starling law, it will also pump more. So preload increasing, afterload is also increasing in case of aortic regurgitation. Preload increasing because diastolic leak from the aorta into the left ventricle during diastole, and afterload increasing due to increase in preload, increase in stretching, and Frank-Starling law, and afterload is also increasing. So that will lead to, if the afterload will increase, then the systolic blood pressure will increase. So this heart ventricle will pump all this blood. So systolic blood pressure is increasing, but diastolic blood pressure is decreasing, because during diastole there will be backflow of blood from the aorta into the left ventricle. So diastolic blood pressure is decreasing because of diastolic blood leaks back from aorta into the left ventricle, causing rapid fall in aortic diastolic pressure. So diastolic pressure is rapidly falling. Diastolic pressure is rapidly falling because there is leak of blood from the aorta into the left ventricle during diastole. So diastolic pressure is falling, but due to increase in afterload and increase in volume overload inside the left ventricle, the systolic blood pressure is increasing. The systolic blood pressure is increased, so but diastolic blood pressure is falling. So that will lead to what happens to pulse pressure. Pulse pressure is SBP minus DBP. So DBP is falling, systolic blood pressure rising. So there will be wide pulse pressure. But in case of AS, we saw narrow pulse pressure, because in case of AS, the systolic blood pressure was decreasing. that was leading to narrow pulse pressure. But in case of air, SBP is increasing, DBP is decreasing, that will lead to wide pulse pressure. So there are some signs of wide pulse pressure. I told you in case of acute air, the signs of wide pulse pressure will be absent. No features of wide pulse pressure. We'll discuss those signs now. So signs of wide pulse pressure is that is because of forceful lateral expansion in systole and rapid collapse in diastole. So this is the most important point I can say here. So it is forceful arterial expansion during systole and rapid collapse in diastole. So forceful lateral expansion in systole and rapid collapse in diastole. This is what leading to signs of wide pulse pressure. So this is what leading to signs of wide pulse pressure. So let's discuss that. So aortic regurgitation, so there will forceful lateral expansion and rapid collapse, forceful lateral expansion in systole and rapid collapse in diastole. This is what leading to signs of wide pulse pressure. So let us discuss all these signs from head to toe. So first on the forehead, we see lighthouse sign. Lighthouse signs means blanching and flushing of the forehead. Blanching and flushing of forehead, it is called lighthouse sign. Then there will be head nodding. Head nodding with each heartbeat. It is called de Musset sign. De Musset sign is head nodding with each heartbeat. Lighthouse sign is blanching and flushing of forehead. And in the eyes we have two signs. One is called Landolfi sign, that is change in pupil size with each heartbeat. So with each heartbeat there will be change in pupil size. It is called Landolfi sign. Another sign is called Becker sign. Becker sign is visible retinal artery pulsations on fundoscopy. So on fundoscopy we will see visible retinal artery pulsation. This is called Becker sign. And pulsation on uvula, it is called Muller sign. So pulsation on uvula, it is called Muller sign. So another sign which is called Quincke's sign. Quincke's sign means visible capillary pulsation on the nail bed. On the nail bed, if you place the flashlight inside the below the nail, you will see visible capillary pulsation on the nail bed. It is called Quincke's sign. And another sign is called water hammer pulse. Water hammer pulse is characteristics of air. So pulsations on the spleen can be seen. It is called Gerhardt's sign. Gerhardt's sign is pulsation on the spleen, and Rosenbach sign is the pulsation on liver. Gerhardt's sign is pulsation on spleen. Rosenbach sign is the pulsation on liver. So another sign is Hill sign. So it is the most characteristic sign, Hill sign. Hill sign is lower limb BP minus upper limb BP is more than 20 mmHg. So lower limb BP is greater than upper limb BP. The difference is more than 20 mmHg. So lower limb BP is more than upper limb BP. It is more than 20 mmHg. It is called Hill sign. It's the surest sign. So Hill sign is the surest sign. Lower limb BP is greater than upper limb BP by more than 20 mmHg. Name a condition in which lower limb BP is less than upper limb BP. That is coarctation of aorta. In coarctation of aorta, lower limb BP is less than upper limb BP. Name a condition in which lower limb BP is greater than upper limb BP. That is aortic regurgitation. So what other signs? Pistol shot sound over the femoral artery. Pistol shot sound over the femoral artery is called Tropp sign. Tropp sign is pistol shot sounds over the femoral artery. Pistol shot sounds. Another is called Durowiec sign. Durowiec sign is intermittent to and fro systolic and diastolic murmur heard with light compression on the stethoscope over the femoral artery. If on the femoral artery we place the stethoscope, we will heard a systolic and diastolic murmur heard. So what are other signs? Sherman sign. Sherman sign is dorsalis pedis pulsation. It is visible in patient who are more than 75 years old. Sherman sign is dorsalis pedis pulsation visible more than 75-year-old patients. What is called Sherman's paradox? Sherman's paradox is seen in case of Friedreich's ataxia, in which the disease severity becomes more severe and severe with the upcoming generations. So in the grandfather the disease is less severe, in the father the disease will be more severe, and in the son the disease will be more and more severe. This is called Sherman's paradox. This is Sherman's sign, dorsalis pedis pulsation visible in people more than 75 years old. Another thing is called Lincoln sign. Lincoln sign means the crossed leg bobs with each heartbeat. It is due to prominent popliteal pulsation. The crossed legs bobs with each heartbeat. The crossed legs bobs with each heartbeat due to prominent popliteal pulsations. It is called Lincoln sign. So these are the signs Here you can see Quincke sign, visible capillary pulsation on the nail bed. Dorois sign, intermittent to and fro systolic diastolic murmur generated by light compression of stethoscope with the bell. Waterhammer pulse, high volume abruptly collapsing pulse, high volume abruptly collapsing pulse. And drop sign is pistol shot sound over femoral artery due to sudden systolic expansion and diastolic collapse. This is the main pathology here: sudden systolic expansion and rapid diastolic collapse. Becker sign is visible retinated pulsation on fundoscopy. Moeller sign is pulsation on the uvula. Rosenbach sign is pulsation on the liver. Gerhardt sign is pulsation on the spleen. Main sign is fall in diastolic blood pressure by more than 15 mm of Hg when one arm is raised. So when one arm is raised, there will be fall in diastolic blood pressure by more than 15 mm of Hg. Sherman sign, nostralis pedis pulsation visible in more than 75 years. Lighthouse sign, blanching, flushing of the forehead. So these are all the signs you see in case of aortic regurgitation. So what is the difference between collapsing and pseudo collapsing pulse? You see Waterhammer pulse which is seen in case of air. Now discuss about collapsing and pseudo collapsing pulse. Collapsing pulse is seen in case of air. Pseudo collapsing pulse is in case of MR. Collapsing pulse, these are both are associated with rapid upstroke and rapid downstroke. Rapid upstroke and rapid downstroke. Whereas in case of collapsing pulse, there is ill sustained apex. In pseudo collapsing pulse, there is well sustained apex. So this is ill sustained apex, well sustained apex. So this is pseudo collapsing. This is collapsing pulse. Collapsing pulse in case of air, pseudo collapsing pulse in case of MR. So this is normal volume, and collapsing pulse is high volume. It is ill sustained apex, it is well sustained apex. Both are rapid upstroke, rapid downstroke. So this is the difference between collapsing and pseudo collapsing pulse. So another finding, pulse finding is in case of air, this is called pulsus bispherians. Pulsus bispherians means two peaks in the systole. Two peaks in the systole. This is two peaks in the systole. P, T. P is called percussion wave, T is called tidal wave. If P is greater than T, it is in case of hypertrophic cardiomyopathy, percussion wave, tidal wave. P less than T or P equal to T, it is severe AR or mild to moderate AS. So percussion wave, tidal wave, pulsus bispherians, that means two peaks in the systole. Pulsus bispherians is in case of AR, where P is greater than T, P is less than T, or P is equal to T. And where P is greater than T is hypertrophic cardiomyopathy. So what are the other type of pulse abnormalities we can discuss here only? So let's discuss that, the other type of pulse abnormalities. So one is called pulse bigeminy. Pulses bigeminy. So what is pulse bigeminy? Every alternate pulse is due to a premature ventricular contraction. So every alternate pulse is due to a premature ventricular contraction. So this is normal pulse, this is pulse due to PVC. So this is normal pulse, this is pulse due to premature ventricular contraction. Normal pulse, pulse due to premature ventricular contraction. So this is pulsus bigeminy. This pulsus bispherians means two peaks in the systole. This is pulsus bigeminy. And pulsus bigeminy, that is seen in case of digoxin toxicity. Pulsus bigeminy is in case of digoxin toxicity. It is called pulsus alternans. Pulsus alternans means regular alteration in pulse amplitude. This is in case of LV systolic failure. Regular alteration in pulse amplitude. Pulsus alternans means regular alternation in pulse amplitude in case of LV systolic failure. Then pulsus parvus attardus, seen in case of AS, we have discussed that. Severe AS, very severe AS, low volume and slow rising pulse, pulsus parvus attardus. Pulsus bispherians, two peaks in the systole, seen in case of AR and HOCM. In HOCM, percussion wave is greater than tidal wave. In case of AR, the percussion wave is equal to or less than tidal wave. So what is pulsus paradox? Pulsus paradox means, so suppose this is heart. So this is superior vena cava, this is pulmonary veins, this is aorta, this is pulmonary arteries. So When we are inspiring, with inspiration there is increased blood flow to the right side of heart. So why that is happening? Because the SVC, superior vena cava, is extra thoracic and extra pericardial. Pulmonary vein is extra pericardial but intrathoracic. All these parts are intrathoracic except SVC. So when you are inspiring, the lung is compressing the heart, so there is decrease in negative pressure is creating inside the pressure is decreasing inside the all chambers of heart including pulmonary vein. But due to this superior vena cava is extra thoracic, so there will be no decrease in pressure inside the superior vena cava. So there is a gradient created. There is low pressure zone inside the right atrium, high pressure zone or normal pressure is inside the superior vena cava, so the blood will flow more to the right atrium. So there will be, during inspiration, more blood is flowing to right atrium. So when this blood is flowing to right atrium, what happens now? There will be increased volume overload inside the right ventricle. Now this ventricle will push slightly this interventricular septum. When this ventricle is slightly push the interventricular septum, so this will be like this only. This will be like this only. So now what's happening? The LV size is decreasing for a small period of time. So LV size is decreasing in small period of time, so that will lead to fall in SBP, systolic blood pressure. So that will lead to fall in systolic blood pressure. So inspiration leads to fall in systolic blood pressure. Clear? So this is normally about less than 10 mm of Hg. This is less than 10 mm of Hg. If inspiration is leading to fall in systolic blood pressure more than 10 mm of Hg, if inspiration leading to fall in systolic blood pressure more than 10 mm of Hg, the pulse will be weak. Obviously, it is called pulsus paradoxus. So after inspiration, there will be fall in systolic blood pressure by more than 10 mm Hg. It is called pulsus paradoxus. Why this happens? Because during this right ventricular filling, during inspiration, it expands to both sides, expands from here and here also. If this pericardium is fibrosed, in case of constrictive pericarditis or cardiac tamponade, if this is fibrosed, so then it cannot expand towards outside, so it will only expand towards the interventricular septum. That will lead to more decrease in LV size, that will lead to more fall in systolic blood pressure, that will be more than 10 mm of Hg. It is called pulsus paradoxus. It is called pulsus paradoxus. So most common cause is COPD, most common cardiac cause is cardiac tamponade, other causes are constrictive pericarditis. So SBP falls by more than 10 mm of Hg. This is called pulsus paradoxus. So these are the type of abnormalities of pulsus bispherians in case of AR, percussion of tidal lobe, two peaks in the systole, In case of hypertrophic cardiomyopathy, there is also seen pulsus bispherians, but percussion wave is greater than tidal lobe. But in case of AR, the percussion wave is less than or equal to tidal lobe. This is pulsus bispherians and other type of pulses. So JVP will be normal because JVP is a right heart phenomenon, and BP, there will be wide pulse pressure. I told you Hill sign, Severus sign, lower limb BP and upper limb BP. Lower limb BP will be more than 10 mm of Hg. So mid thigh BP is BP in prone position. So lower limb BP we have measure mid thigh BP in prone position. So apex will be hyperdynamic down and out apex, rocking motion. So heaving apex was seen in case of aortic stenosis, hyperdynamic down and out apex due to eccentric hypertrophy and dilatation. So this is eccentric hypertrophy and dilatation, down and out apex. That is rising and sustained apex, heaving apex, that is in case of AS. But in case of AR, due to eccentric hypertrophy and dilatation, there will be hyperdynamic down and out apex. So another few conditions associated with AR. One is nocturnal angina. So high nocturnal angina is in case of AR without any coronary artery disease. So AR patient having no other coronary artery abnormalities, no coronary artery disease, developing nocturnal angina. Why? So while sleeping or resting, there will be bradycardia. When there is bradycardia, there will be prolongation of diastole. When diastole is prolonged, more time available for blood to regurgitate from the aorta into the left ventricle. So more blood will regurgitate during diastole because of bradycardia, decrease in heart rate. So more blood will regurgitate from the aorta into the left ventricle. So that will lead to diastolic pressure falls further. So the aorta, which is originating from the heart, left ventricle, it is supplying the coronary arteries are arising from the base of this aorta. So this aortic pressure is falling during diastole because blood is regurgitating or flowing back into the left ventricle. So this blood flow to this coronary arteries which are arising from the base of aorta, the blood flow will decrease in these coronary arteries. That will lead to decreased blood flow to the myocardium. That will make the patient more prone to develop angina while he is sleeping or nocturnal angina. So Orson's air, blood stolen from the coronaries, coronary perfusion decreased, and this is leading to angina. So nocturnal angina due to bradycardia, blood is stolen from the coronaries, that will lead to angina development in patient with air. So another is LVH is happening here. Not is concentric LVH, it is eccentric LVH. So it requires more oxygen, so that can be another cause of developing angina also. So exercise makes air patient better because exercise leads to increase in heart rate or tachycardia. Diastole is shortened. If diastole becomes shortened, then there will be less regurgitation. So shortening of diastole, less regurgitation, so lead to improvement of some symptom during exercise. So reduces regurgitation volume per beat, so patient feels better. So this is all about relation of bradycardia and tachycardia with aortic regurgitation. So in syphilis, tree bark aortitis and Tumbar S2 is seen. So vasoconstrictions in air. I told you vasodilators were used in management of acute air while the patient is waiting for surgery. So what is the role of vasoconstriction in air? So if there is vasoconstriction in air, there will be increase in systemic vascular resistance, increase in afterload. So there is, if it is increasing systemic vascular resistance or increase in afterload or increase in aortic pressure, there will be more backflow. There will be more backflow. So in air, LV has to eject normal volume, normal systolic volume plus extra regurgitant volume. When there is increased afterload, LV finds it very difficult to eject this blood further, so strict BP control is advised. So if there is high systolic blood pressure, SBP is high in case of patient with air, so there will be increase in regurgitation of blood from aorta to left ventricle because the aorta pressure is rising, systolic blood pressure is rising, aorta pressure is rising, so there will be more backflow into the LV. So this can be worsened. Air can be worsened if you don't tightly control the systolic blood pressure. In case of AS also, we are advised to tightly control the blood pressure because it can hamper while measuring the pressure difference, mean transfer blood pressure difference, which is more than 40 mm of Hg. So this value can be calculated wrongly if there is no tight BP control. So here air, it can worsen, systemic hypertension can worsen air. So vasodilators are used in management of chronic air also. They decrease the afterload or systemic vascular resistance, increase forward flow, there will be decrease in regurgitant volume. So vasodilation is helpful in management of air. Nifedipine and hydralazine, they are used in management of air. So what happens to, now we discuss the heart sound and murmur. So S1 here is a volume overload state inside the left ventricle. So there will be soft S1 because the S1 is floating in the blood, so there will be soft S1 due to volume overload. Another thing is premature closure will cause soft S1. Premature closure will cause soft S1. Normally mitral valve closes when left ventricular pressure is more than left atrial pressure, but here there will be increased LV-EDP due to volume overload. So LV pressure increases earlier due to regurgitation of blood from the aorta, that will lead to premature closure of mitral valve. So due to premature closure of mitral valve, the S1 will be softer because there is more blood inside the left ventricle. LV-EDP is greater than left atrial pressure due to more backflow or regurgitant blood from the aorta. So that will lead to premature closure of a mitral valve, that will cause soft S1. So what happened to S2? S2, if it is valve issue, then there will be soft A2. If it is root issue, then it is loud A2. So valve issue, soft A2, root A2, loud A2. Okay, so S3 is seen in case of LV systolic failure only. S4 is never heard. S4 is heard when atria is pumping against a stiff ventricle. That is, in case of AS, LV concentric hypertrophy, AS is the only valvular heart disease where we found S4. So S3 can be also found in AS if there is systolic failure, and S3 can be also found in AR if there is systolic failure. So murmur is early diastolic decrescendo murmur. Murmur is early diastolic decrescendo murmur. So it is a diastolic murmur, early diastolic, beginning early in the diastole, and it decrescendo, the amplitude is decreasing. So immediately after A2, the murmur is starting. It is best heard in the new aortic area. New aortic area is third left ICS, third left intercostal space is new aortic area. Radiation to the axilla, it is called cholecystral murmur. So this air murmur is based on the new aortic area. So these are the areas we auscultate according to anti-clockwise manner. So suppose this is this is mitral area. Mitral area is in fifth intercostal space, mid clavicular line, 2.5 centimeter medial, and mitral area. Then we have here we have this is left second intercostal space, that is the pulmonary area. This is the left third intercostal space, this is called new aortic area. This is right second intercostal space, it is aortic area. In aortic area we heard the aortic stenosis murmur, but in new aortic area left third intercostal space we heard the early diastolic decrescendo murmur, which is in case of air, best heard in the new aortic area. So it is heard by diaphragm of the stethoscope, sitting and leaning forward position, breath held in expiration, because expiration increases the murmur intensity in case of left sided murmur, so it will be best heard in expiration. Retroversion of leaflet leads to Key-Hutchins murmur. Key-Hutchins murmur due to retroversion of leaflets. It is high-pitched blowing murmur, early diastolic decrescendo murmur. So early diastolic because it starts immediately after S2 or immediately after A2, you can say valve closure. After valve closure, this murmur starts because the valve is not closing properly, and aortic pressure is more than the left ventricle pressure after the closure of valve. If this valve is not closing properly, then there will be more blood flow across. This valve is not closing properly, so there will be more blood flow from the aorta into the left ventricle. So this aorta blood flow will decrease simultaneously. First there will be more blood flow, more gush of blood coming to, eventually the blood flow across this valve will decrease. So that's why this murmur is like this, decrescendo murmur, because the blood flow is maximum after the closure of the valve, or after A2 the blood flow is maximum. After that this blood flow is decreasing, that's why the murmur intensity is also decreasing. So as diastole proceeds, the aortic pressure falls as diastole proceeding, because the blood is coming back into left ventricle, so aortic pressure is falling. So as diastole proceeds, aortic pressure falls and LVP rises, left ventricle pressure rises due to filling. So the murmur intensity, the pressure gradient will decrease. So murmur it decrease into decreasing. Murmur is maximum intensity after the closure of A2. It is decreasing continuously because as the diastole proceeding, the aortic pressure is falling and the LV pressure is rising. So murmur intensity is decreasing as the diastole is progressing. So another murmur is called Austin-Flint murmur. Austin-Flint murmur, it is in case of severe air, large regurgitant jet flows from the aorta into the left ventricle during diastole. So during diastole, large flow of jet or regurgitant jet flows into the left ventricle. Suppose this is, I can image this. So this is the left ventricle, this is the valve which is open. Now this is aorta, there is a large flow, blood flow. This is the, now this is diastolic murmur. So all these things happening in diastole. Suppose this is the mitral valve, anterior leaflet. Now large jet of blood is coming and striking the anterior leaflet of mitral valve. So when it is striking the anterior leaflet of mitral valve, then the mitral valve will appears to be closed. So this passage will be narrowed, in which the blood was flowing from the LA to LV. So it will act as functional MS, because this valve is closing. So this jet strikes on the anterior mitral leaflet, this jet strike and pushes it towards the closed position. It is functional MS. So what is the murmur heard in MS? There is mid diastolic rumbling murmur. So that's functional MS, also that murmur will be heard. So mid diastolic rumbling murmur at the apex, in the mitral area or the apex, this murmur will be heard. But in neo aortic area, the air murmur, early diastolic decrescendo murmur will be heard. So air murmur becomes louder with hand grip, because when there we are doing hand grip, there is increase in systemic vascular resistance, that will lead to increase in aortic pressure, that will lead to increased blood flow across the valve, that will increase the intensity of murmur. So air murmur becomes louder with hand grip due to increase in systemic vascular resistance or increase in afterload. In case of severe air, what murmurs we will see? In severe air, Austin-Flint murmur will be heard along with mid diastolic long rolling murmur at the apex, early diastolic decrescent murmur at third left intercostal space, that is neo-aortic area. Neo-aortic area will hurt the early diastolic decrescent murmur, and in the apex will hurt the Austin Flint murmur, that is the mid diastolic rumble. So management of AR is symptomatic AR, aortic valve replacement surgery. Asymptomatic severe AR, LV failure is there but patient is asymptomatic. And then there is 55-50 rule. 55-50 rule states that if the ejection fraction is less than 55% or left ventricular end systolic diameter at the end of systole, so this is left ventricle, suppose at the end of systole the diameter of the left ventricle, if it is more than 50 mm, at the end of systole, left ventricular end systolic diameter. So after the systole, if the ventricle is enlarged due to eccentric hypertrophy, ventricle normal size, suppose this was this, now it is enlarged to this. So when it is more enlarged, the prognosis is more poor or this condition is more severe. So if it is more than 50 mm, left ventricular end systolic diameter is more than 50 mm, that is an indication for aortic valve replacement. Symptomatic AR will do aortic valve replacement surgery, but in case of asymptomatic severe AR, this 50-50 rule, ejection fraction less than 55% or left ventricular end systolic diameter more than 50 mm, that is also an indicator for aortic valve replacement surgery. Acute AR I have discussed. So the difference between acute and chronic AR: acute AR, the LV size is normal, chronic AR LV is dilated. In acute AR it will present with pulmonary edema, cardiogenic shock, hypotension, but it is all these things, cardiogenic shock, hypotension, these are the late presentation in case of chronic AR. So pulse pressure is wide, there are signs of wide pulse pressure, we have discussed that in case of chronic AR, but in case of acute AR there is not wide pulse pressure. Shock will be present in case of acute AR, shock will be late presentation in case of chronic AR. So this is all about aortic regurgitation.